welcome to BNEWS In Depth. I'm your host, Sydney Bowles. May is Mental Health Awareness Month, a time when groups around the country focus on ending stigma, fostering education, and advocating for policies that support those impacted by mental illness. Here in Burlington, clinicians in town agencies and hospital settings have noticed an increase in the need for mental health supports, so we thought we'd take a moment to talk to those providers about what they're seeing and what they need. Later in this hour, I'll talk to Chrissy Conceison, District Director of Mental Health in Burlington Schools, and Karen DiRienzo, Mental Health Clinician with the Burlington Police Department. But first, I spoke with Erica Savino Moffatt, a nurse practitioner at Lahey Hospital Medical Center who works with people experiencing mental illness on a daily basis. Erica works with adults in Lahey's Department of Psychiatry and Behavioral Medicine, and she also sees child and adolescent patients outside of the Lahey system. She was trained at Boston University's School of Graduate Medical Sciences and Boston College's Connell School of Nursing. I started by asking her about the value of Mental Health Awareness Month.
For me, every month is Mental Health Month for obvious reasons. I'm always a huge proponent of it. I think it's really important that it's a part of the conversation for all of us all the time. What's really lovely is that it's kind of come into the public for as a thing that we can and should be talking about, notably without shame.
Yeah, I think stigma around this is something that has been in the conversation. I think it wasn't too long ago, right? It wasn't decades, it was years where it really felt difficult and really brave to talk about experiencing anxiety and depression. And it still requires some bravery, but I think there's more, that door is a little more open. Does that feel right to you?
It does. I do think that the tide is very much turning, although much more slowly than people like me might like to see. I do think it's become part of the public discourse that you see figures like Simone Biles, leaving the Olympics for the Twisties, which has a large mental component, that we're seeing a lot more athletes be upfront about their mental health challenges, or musicians that need to take time away from tours. Shawn Mendes, a couple of years ago, suspended his tour because his anxiety was getting a little bit much. And I think it's a really beautiful thing. Mental health is a set of issues that have been around for as long as there have been people, but our sort of simple refusal to accept it as a real thing has been problematic for generations, and it's nice to see that start to change so that people get the treatment that they need.
I wonder if you get the sense that some conditions or expressions of mental health challenges are being destigmatized faster than others, right? I think of something like schizophrenia or like borderline personality conditions that might feel a little bit, where that conversation still feels different.
I think there are definitely some mental health struggles that have been sort of not depathologized, but destigmatized more than others. I don't think that we really bat an eyelash at the idea of somebody having anxiety or depression or ADHD, for example. But I think conditions like a bipolar disorder, a schizophrenia, personality disorders like a borderline personality disorders, they tend to kind of move in waves on things like TikTok, but that they're kind of a little more unwieldy to understand for average people without a mental health degree. And so wouldn't necessarily expect those to get destigmatized as fast because they're more complex disorders.
Are there ways that we can think about or talk about those more unwieldy conditions that would sort of push us in that direction, do you think?
I do think we're starting to see that. I think autism is one of those conditions that's very much kind of on the bubble, that most kids know somebody with autism. Most adults probably also know somebody with autism, but just don't realize that they do. There is now a Sesame Street character named Julia who has autism.
Really? I didn't know that.
Yes, they introduced her, I think, a year or two ago.
That's wonderful.
And so we're just starting to see that these people are just people in our society. They are the people in our neighborhood, to quote from Sesame Street. And that I think that as we start to understand from the autism perspective, that we understand that neurodiversity can be a good thing, and that we think of neurodiversity in lots of ways, including folks that have some mood challenges, like our folks with bipolar disorder, and those with thinking disorders, like the folks that we know with schizophrenia spectrum disorders.
There really is such a spectrum of things that we put under the umbrella of mental health, and I guess from a lived experience perspective, that can maybe make it harder to figure out the distinction between what's part of the normal human experience of the ups and downs of life, and when is it maybe time to seek professional help or explore a diagnosis. So how do you think about finding that balance?
In the sense that I think of medical health and mental health as kind of equally important and to be treated in largely the same in a lot of ways. Much as if you'd had a cold that dragged on for more than 2 weeks, you'd call your doctor and say, hey, is there anything I can do about this? I think about mental health the same way. So what we want to look for in terms of how to know when to seek help is when we see that people's behavior changes, that they're consistently withdrawn, or they're not eating or sleeping, that they're retreating from relationships or abandoning like favorite activities. From my perspective, it's always okay to get it checked out.
Yeah. I want to talk a little bit about the conversation that we've been having culturally about a teen mental health crisis. Does that language feel right to you, a mental health crisis?
Yes, it does.
How are you seeing that play out in your work world?
I think adolescence has always been a difficult time for humans.
No kidding.
It's the time in our lives where we try and figure out who we are in the world, which is pretty gnarly and complex in the best of circumstances. And then, of course, we had COVID, where it, for the teen population, really isolated teens from their peers, which is largely how they figure out who they are. Do I believe what this person believes or what this other person believes? What feels right to me? What am I passionate about? So because of the nature of COVID, we had to cut kids off from their peers, and the loss of that socialization was really hurtful to them. Then you have to also account for the rise of social media and how ubiquitous it is in our lives. Teens today in my care report that they feel incredible pressure from social media. I'm old enough that when I was a kid, if I was bullied, the bullies couldn't get you once you left school. But social media has created a 24-hour opportunity for that bullying to happen in lots of ways, outright mocking, exclusion, all kinds of things. And the other thing is, too, is that there's a social media pressure to have this Instagram perfect life. That you're cut off from your colleagues, your kids of the same age, but also there's a lot more academic pressure that we look at what just even the process of applying to college is and how that's changed. When I applied to college, the average was about 5. Kids these days are applying to 15 or more. And so there's incredible academic pressure to be able to get into all of these schools. When you put all that together, it gets really difficult to figure out who you are and what you stand for in this kind of artificially governed vacuum.
It feels like such a big problem that to ask what to do about it, even from a clinical perspective, from a societal perspective, those are really big, hard questions, and it feels unfair to ask them to you. Are there 2 or 3 things that you think we can be doing to help with that?
So the Surgeon General has put out a warning about teenagers on social media. I think that's great. I would not dare disagree. However, I would acknowledge the more pragmatic reality that teens are on social media and they're gonna do it. I think it's about the conversations that happen at home, about what social media means, that it's like a sanitized, prettified version of folks' lives, and about helping teenagers and sometimes even tween users of social media understand that you're not a better person because you get more clicks, more views, more likes.
Yeah, I mean, I'm just thinking, I should have done the research before I said this out loud, but I was listening to this fascinating conversation. I think it was on the Ezra Klein show. I'll put the details on this in the notes around this show. But it was a conversation with an expert on the teen mental health social media area who was discussing the research showing that teens who were asked, would your life benefit by getting off social media? Do you want to get off social media? Said no. But then if the question was, do you wish that this didn't exist? The answer was yes. This idea that if none of us had this, I would be okay not having it. It's sort of the peer pressure, the like, I can't miss out, but gosh, I wish this wasn't a factor.
Yes,
it feels so, yeah.
It is very much a FOMO, a fear of missing out is what keeps teens on it. And then you hear that teens who do either because they're forced by their parents as some sort of consequence or because of circumstances, they're out of the country, whatever, who do take a social media break, pretty invariably do report better mental health. It's that culture of comparison and, like I said, sort of prettification. It's not just for teenagers too, it's very much for adults that
no kidding.
A lot of times with anxious adults that one of the interventions that I have for them is to get them to kind of reduce their time on, especially news websites, but also social media too.
Right. I mean, I think this for me is one of my sort of bugaboo questions that I think about all the time is that we're living in really difficult times. There's so many really challenging things that we read about in the news, that we interact with on a day-to-day basis. Economic circumstances are really tough. Global circumstances are really tough. The climate is really tough. I think it can feel like there's a natural response to looking at the world and to experience suffering because of the world that we live in. So as a clinician, how do you, it can't just be, buck up. It can't just be individual solutions, right? When we're living in a structure that is really difficult.
I think a lot of those problems, war is not a new problem.
Yeah.
Climate change is not a new problem. It's been happening for generations, albeit perhaps a little more slowly in many years past. I don't know. But all of these things are things that have always been problems. But where we live in the information age and we find out what happened across the world within seconds, and where you've seen the evolution of a lot of news sources to be largely based in clickbait and views. It's like there's a theme here, that can get really destructive and unhealthy for people's mental health. And again, that's when I encourage folks to back off on their use of, news sources, and to really think about what news sources they use too, and social media as well. Social media can be a really wonderful tool. It can bring people together, and there's lots of philanthropy things that go on it. But if you don't have a good sense of your bearings within that space, it's very easy to lose your mental health to it. The algorithms that are built into some of our mental health, particularly platforms like a TikTok, have been shown to be pretty problematic in that once you like or spend a certain amount of time viewing something, the AI in it feeds you more of that content. So that can be even more problematic on top of just how hard the world is.
Right. Yeah. I mean, it's a real difference between, 20, 30 years ago, you read the paper in the morning and then that you sort of put that aside. And now it's just a sort of constant onslaught of information. Yeah. I want to stay in this realm of sort of structural stuff for a minute. I think there's information out there about the challenge of finding care, right? Whether, it's because of health insurance or because of, a difficulty of finding a clinician who's got availability. It can be a real difficulty. I know this just sort of anecdotally from my friends who spend, hours and hours and days and weeks trying to find care. This is not a problem that you can solve, or maybe you can, I don't know, but I think like these are real structural issues. So what do you make of those challenges as someone who's in this world?
I think that COVID really threw gas on the fire and accelerated and brought to the fore a lot of mental health challenges that people were maybe already having, that COVID made worse. I do think, though, that, I'm the eternal optimist. I think there's hope there. Yeah. I think it's about how we as clinicians and as a community are relentless in sort of letting people know what resources there are. Because if you're looking for a resource, there are resources out there. Burlington residents, for example, have the option of accessing Project Interface, which you can Google for the phone number, and they will help you match with a therapist within a couple of weeks. If you are, for example, a primary care patient within the Lahey system, that they have embedded psychiatrists and embedded therapists to help folks find short-term treatment. And the psychiatrist can advise your primary on what medications you might need to help get things better. And there are lots of other resources in the community.
I actually wanted to talk about that a little bit. I know there's been a lot of conversation recently about 988, the crisis suicide prevention hotline. Do you have any thoughts about how that's going?
Well, the numbers don't lie. It's going fantastically well. So 988 was established in July of 2022. Since then, there have been over 9.6 million contacts by telephone, chat, and text.
And that's nationally.
In just the month of March of 2024, so last month alone, there were 542,000 contacts. So it works, and people are using it. Yeah. The need is very much there, and I think it's a great thing. It's an incredible asset for all of us in the mental health community that we now have a resource to send our folks to when we're off hours. So it does a lot for folks to know that there's help anytime. Just having that in your back pocket staves off a lot more crises than you'd think.
What happens when you dial that number?
So when you call that number, you're connected to the national hotline. There's a trained counselor on the other end to listen to what you have to say, to refer you to other resources. If something is an emergency and it's deemed to be so, they can help get a local emergency response directly to you.
So you're talking to a person.
Yeah, a human, not a machine, not a bot. And that makes all the difference.
That makes a huge difference.
Yes.
Yeah. We're going to come to a close in the next minute or two here. I wanted to ask if there are any other resources that you want to shout out or point people to in our last couple minutes.
I think there are lots of resources. 988 is a great resource, but if 911 is the thing that comes to your head, we want people safe, and so it's okay to use. There are also local community behavioral health centers in communities near Burlington that can be really helpful for people. Really the thing, I think the take home is that I know it's hard to find a therapist right now. There is hope. Lahey and other organizations have a lot of things that they can do to get you some help, even though it seems like a difficult mountain to climb. And that really, I'm somebody that believes that treatment works and that you want to reach out to somebody if you're not feeling okay. And if you think someone else isn't okay, it's okay to ask them point blank. It's okay not to be okay is really an idea that I'm grateful is really taking root in our community.
That was Erica Savino Moffatt, a nurse practitioner with Lahey Hospital and Medical Center. Next, we go to Burlington Public Schools, where the district has been adding supports for students experiencing mental health challenges, especially in the years after COVID. Chrissy Conceison is the District Director of Mental Health in Burlington Schools, and we started by talking about what exactly that job entails.
The Director of Mental Health role is relatively new to Burlington. This is my third year in the role. I oversee all of the school counselors, K through 8, and then all of the school adjustment counselors and social workers, K through 12. I also am in charge of implementing the social emotional learning program, which we currently have integrated into our preschool all the way through 8th grade. So it kind of encompasses all of that.
I was wondering if you could tell us a little bit about the landscape of mental health in school, which I know is an annoyingly large question, but I think that there's a real sort of question, I think, in the community, nationally and here in town, of what the role is of schools in addressing a real student mental health crisis, what the school's job is, I guess, in that world.
So it's a big question, and I think that there are a lot of different ways to answer it. I think that our goal in the counseling department, from a tier 1 level, which is what reaches all students, universal, is to have our students feel a sense of belonging and purpose in school, to have them feel safe, to have them have an adult that they can go and they can speak to, that they can connect with. There are also students who need more intensive level of support. And we try to meet that level of need, whether it's through one-on-one check-ins or counseling sessions, or through some group interventions. And then we have other students who need even higher levels of support, where we have students who are on social emotional goals through IEPs. I think one of the things that sometimes is misconstrued is our goal is to make sure that students are successful in school. We want them to come here, we want them to feel safe, we want them to be able to work through whatever's happening in the day so that they can access the curriculum and access their classrooms, whether it's in our elementary levels all the way up to our high school level. But also nationally, we're in a mental health crisis, specifically for children and adolescents. And right now, what they're saying is from onset of symptoms to students actually receiving true treatment nationwide is about 8 years.
Wow.
So as a school district, we are in a prime space to be able to intervene much earlier because we have access to the students, we see them daily, we're able to maybe realize at an earlier rate that something might be going on. So that's where we have a lot of partnerships as well. So if a student is needing a level of mental health support that may not be appropriate to address in school, that's where our partnerships with Burlington Youth and Family Services or Interface or Cartwheel Care come in, where we can offer some real evidence-based treatment for students at a much quicker pace than perhaps if they were to try to go out into the community themselves.
Right, right. I mean, I think this is a tricky conversation because the spectrum of ways that sort of social and emotional needs and mental health concerns is so broad, right? It's everything from maybe I raise my voice at my teacher when I shouldn't have, all the way to really concerning like mental health conditions that need medication and long-term care. Correct. And those are really different kinds of conversations.
Yes.
But I think there is kind of this middle ground, what you were talking about, of this like national mental health crisis, that I think maybe it's fair to talk about as just an increase in, not just, but an increase in anxiety and depression.
Absolutely.
Kind of broadly among middle to high school students, maybe? Does that seem fair?
I think that's fair. I think that we were seeing an increase in anxiety, depression before the pandemic, as everyone's heard all over the news. Yeah. That has increased post-pandemic. But we're also seeing some of those symptoms that we traditionally saw arise in students who were in the middle school and the high school, now starting to present in even elementary age students. So we're trying to be very cognizant and proactive about the supports that we can offer students. Whether it's, some informal lunch bunches or social skills or SEL skills, targeted group lessons, to more explicit evidence-based groups that our staff has been trained in that address anxiety or depression.
I mean, I want to sort of play devil's advocate, I guess, and I want to play devil's advocate from the position as someone who has struggled with anxiety, depression, and gets it. I think for a long time, the conversation around mental health has been, that's just what being a kid is. It's hard. It's tough. Are we just better at addressing it? Are we better at noticing it? Or is there an increase? Do you know what I'm saying?
Yeah. I think it's all of the factors. I think that I think there, especially in even, the students in the younger age, there is still stigma around mental health, but I think there has been a decrease in stigma. It's more widely talked about. It's more widely spoken about. I think that they are more willing to come and seek help or ask for suggestions. I also think that as adults, we're being more cognizant of signs and symptoms that we might be concerned about. That's not to say that every single student, I think some of the things that we talk with the students about is that stress is not a bad thing. We all have stress. We all need a level of stress or anxiety to function in life.
And to grow.
And to grow, right? We talk a lot about a scale with, especially some of the high school and middle-aged students, where a level of anxiety prior to a test or a sporting event is what propels us to grow, to do our best, to succeed. It's when it kind of goes over the hill where it paralyzes us, or we're experiencing kind of those responses of flight, that's where we want to, make sure we're teaching coping strategies and skills so that they can, again, maintain and do the best that they can in the classroom environment.
So maybe a month ago, a couple of weeks ago, there was an announcement that the school is beginning to pilot a collaborative care model.
Yes.
Can you sort of give me the 10,000 foot view or the explain like I'm five kind of level of what that is and how it's different from what we're doing now?
Sure. So I think the 10,000 foot view it's a partnership with multiple different agencies, a primary care office out of Arlington, a Accelerate for the Future, which is a privately funded company, and Brookline Center for Mental Health. And the goal is to bring more supports into the school. Specifically, we're going to pilot at the high school, a case manager, and also a licensed clinical social worker or a licensed mental health clinician. Students it's going to be insurance blind, so anyone will be able to access it. It will require consent, and parents need to be aware of what they're consenting to, as well as students specifically. But I think one of the benefits and hope of this model is that we're really utilizing insurance as the cost-effective mechanism rather than the school district paying per se. So we're utilizing people's private insurances or mass health insurance to supply the mental health support that the student needs without necessarily having to pay out of pocket for a partnership.
I think that's really helpful. So how much do you imagine this would bolster our capacity to offer care, if that makes sense?
So I think we're going to start very small, and purposely so. I want to make sure that we have a clear understanding of what what the program is, that we're doing appropriate referrals, that the parents and students who participate in it feel comfortable with what services they're receiving. So for the first year, we're anticipating starting very small and being strategic about our referrals. I think that the hope would be that if it is a positive experience for all of the stakeholders involved, that we would be able to expand and grow it. But for next year, I think the goal is to kind of make sure that we're being thoughtful, strategic, partnering with families, and that everyone's feeling comfortable with this model moving forward, because it is a new model for us.
Yeah. I guess it raises a question for me of like how many of an alarm fire is this? The mental health challenges in schools. Is this something that, this is your job, right? You deal with this every day. Is this something that like you care for these students, it's under control, you're sort of doing all the things, or is this something that genuinely feels larger than the district's capacity to address right now, and there really is a need for like, let's throw some spaghetti at the wall and see what sticks? Maybe that's not the most the best way to frame that, but you know what I'm saying? That sort of spectrum of like how big of a concern is this?
So I don't want to say that the collaborative care model is throwing spaghetti at the wall, because I think
not the right metaphor. Yeah,
we've spent a year kind of trying to internally, before kind of it got announced a couple of weeks ago, working through a lot of the questions and thoughts that I'm sure the community is coming to themselves right now. So we've talked a lot about HIPAA, FERPA, how this is going to look in the school. Is it appropriate to do clinical interventions in the school? And if so, like, what is the appropriate level for that? So I just want the community to know that those conversations have been happening. This is not something that we just kind of came up with a couple of weeks ago and we're like, we're just going to go. Yeah. But how big is the emergency? So I think that's an interesting question, just because I think it would depend on the family and the student that you ask the question to. I think that we have families and students who are very much struggling with significant mental health needs, who are looking for licensed, evidence-based treatments, who are hoping to get them sooner and are struggling in the community to find a clinician or a practitioner that they are able to work with, whether it's due to commutes or insurance issues. There's a lot of factors that play into that. We have students in this district who struggle with mental health, who do participate in outpatient programs and hospitalizations. And I think for those families and students, this is a true crisis, and it's very difficult right now in Massachusetts. And I would assume nationwide, but even for them, a lot of the services are very short term. And there's a lot of transition. So really trying to help provide more consistency. But I also think that, that's speaking to the tier 2 and 3 services. But I also think that this community, like, we are focused on wanting our students to have a sense of belonging in our schools, to feel included, to have a sense of safety, both physical and psychological. And I do think that's kind of where the SEL program is focusing, to try to create that community, embed some of those positive strategies, so that the hope is, with that internalized, hopefully we're not reaching a point of needing more intensive supports. Yeah,
let's talk about that. I think social emotional learning is kind of, we've been talking about it a little bit more in the last couple years. So I wonder if you could just talk about how if it's something that schools have always done that we're applying a different name to, or sort of, how it fits into what schools do.
Yeah, I think, it's funny you say that, because I actually think that social emotional learning has been something that has always been present in schools. My mom was a 6th grade teacher. She's retired now, and she was like, well, we did all this stuff. We just called it different things. And
Did she say what they called it, just out of curiosity?
I think, sometimes it was just like creating a culture of belonging, creating classroom norms, making sure that everyone had space and equity of voice. All of those things are part of SEL and social emotional learning. We've just we've given it an overarching term. Here in Burlington, we've been doing social emotional learning for a long time. So parents and caregivers might have heard of responsive classroom, morning meetings in our elementary school where the kids come in and they sat on the ground and they talked about how perhaps their day was, or there was a question or a prompt that started the day. That was social emotional learning, and we're still doing that. We're still hosting our morning meetings. We're still working through that. But one of the things we wanted to be very explicit about was doing some explicit SEL curriculum. So what we did last year is we had a committee of it was open to all educators across the district, anyone who wanted to be part of a committee to look at different SEL curriculums. We did a district-wide survey of our educators to say, what would you really think that our students need to focus on? What would you like to see a part of this curriculum? Do you want to see them working on social awareness, self-awareness, optimistic thinking? There was a long list, and we took the results from that survey and really went through the curriculums and said, does this fit for what we want to bring to Burlington? And we did look at, a good number of curriculums, and I can say the committee unanimously decided on the curriculum that we decided on.
It was Wayfinder.
It's Wayfinder, yes. Okay. And I think it's been a really positive experience thus far. We've done a lot of professional development for staff, pre-K through 8. Most of our professional development days have been on the curriculum so that teachers feel like they've had access to it, that they've had coaching, that they feel comfortable with how to roll the curriculum out during the SEL blocks.
Can you give a couple of more examples of some of the specific kinds of things that SEL can look like, maybe across different grade levels?
Sure. I think one of the things that Wayfinder does really focus on is they focus on creating a sense of belonging for students. So opportunities for students, and it's a very interactive platform. So there are times when the students are seated at their desk and they're maybe learning something or going through something, but there's also a lot of interactive games. So where they're up, they're moving around, they're doing some interactive play of social awareness. You take a turn, I take a turn, talking about, you may have things that you really like and I may have things that I really like, but having two different likes is good, and we should appreciate that, you may succeed at one thing and I may succeed at another thing. So I think a lot of it is focused around that. I think sometimes there's confusion around social emotional learning and mental health, and they somehow overlap in the Venn diagram of all of it. But social emotional learning is really promoting positive social interactions. Mm-hmm. It's something that we as adults use every single day. It's how you interact, how you understand someone else's perspective, how you approach difficult conversations, how you are sure about yourself and how you can present yourself. It's really teaching all of those skills that what used to be called soft skills in the workplace that are so important now.
I hope that it makes sense to include these in a conversation about mental health. My feeling as someone who's not an expert in this is that, without that underpinning of confidence and security in your thought process, mm-hmm. and in your ability to relate to other people, a mental health, a slight mental health concern could become bigger, or through the use of those interpersonal skills and a mm-hmm. sense of self, you can have tools and resources to find support.
Absolutely. Yeah. And I think that part of the Wayfinder curriculum is integrating some of those strategies and skills so that students can feel certain within themselves, but also it's an opportunity for them to build a different kind of rapport and connection with their classroom teacher, mm-hmm. Where they're really authentically getting to know their classmates, but also their teacher in a different way. And I think that is really important. We often ask students, whether it's in our school climate survey or in the youth risk behavior survey in our middle school and high school, do you have one adult within the school system that you could go to if you needed to? Mm-hmm. And we actually, our results are very positive, but we still have room for growth. I think we would love to see 100% of our kids say, I have an adult in the school who I trust and I could go to. And I think that the goal with our social emotional learning programming is that we're creating opportunities for those relationships to foster.
That was Chrissy Conceison, Director of Mental Health at the Burlington School District. And lastly, we turn to the Burlington Police Department, where Karen DiRienzo has been working for about 5 years to assist officers on mental health-related calls and serve as a resource to the community with long-term needs and accessing support. Let's take a listen.
I am a mental health clinician, and I've been embedded inside the Burlington Police Department for a little over 5 years now. And I think my role is multifaceted. It has a couple components to it, and I think they all work together. So one of the main things that I do is I function as a co-responder, which means that I can get dispatched out to calls that have a mental health component. I will get in the cruiser, I will arrive on scene with the officers and interact with them as a team approach to a mental health situation. And it's unique. As years ago, the officers didn't have that. So the mental health calls were something that they had to handle alone. But now I feel like having a mental health professional on those calls adds another dimension to a police response that wasn't there before. And sometimes just me being a civilian and in plain clothes and not uniform could be like a very comforting factor for a lot of people. So that's one facet of what I do. The other thing, the bigger piece is mostly the follow-ups. So if I'm not responding on scene with the officers on a call, I am doing follow-up. And follow-up takes many different routes and can be many different things. It could be a one-time check-in after 24 hours after a police response that the officers may have noted that there's a mental health piece that needs some type of support or guidance. That case would come to me as a referral, and I usually follow up within 24 hours. So it could be a one-time check-in with a family after a police interaction, or it could be ongoing. It could be somebody struggling with an issue, and I can continue working with that individual or family. And lastly, I feel that I'm a resource for the town of Burlington. Anybody in town can call me. I'm easy to access. The mental health system is a very challenging system to navigate. So sometimes I just get phone calls from folks in town that just, have someone in their family that's struggling and they just want to know what route to go, what resources are out there. Because a lot of people don't know. It is, like I said, it's a challenging system to navigate. And if you're not in the mental health field, it's overwhelming. So you want someone to help guide you through. So that's another piece of what I do as well.
Thank you. I wanted to talk a little bit about the going out on calls piece. Mm-hmm. I think for many of us, that's kind of a fascinating and interesting maybe component of the job. I understand that there's privacy concerns here, and I wouldn't want you to be too specific in a way that could sort of risk anyone's privacy, but could you maybe describe a little bit or give a couple examples of the kinds of situations that you might find yourself called out on?
Yeah, and so I don't go on calls alone, so that's definitely a policy that we follow. I get dispatched out only by a lieutenant or a sergeant will okay it and let me know that this is a case that's appropriate for me to go. Sometimes I'm sitting in the cruiser while the officers go in and just get a better sense of what's going on, and I'm called in a little bit later. Other times, especially if it's a repeat person that I know, we're going in together at the same time. So the calls vary. Some of the calls are, for example, a family member saying that their 17-year-old is very depressed and not getting out of bed, and they're really concerned. The child may have made some self-harm statements, and they want somebody they need some assistance seeing if their child needs to go to the hospital or not. So that's one example of somebody struggling with mental health in the moment. It could be a crisis point where somebody is really escalating and a family doesn't know what to do, and somebody could be very agitated and they just need somebody to talk them down. So a lot of what we do is de-escalation. Someone's up here, we really want to try to calm them down. So together with the officers, we use our de-escalation skills to try to manage that. And it's not only just mental health calls. It could be someone who just experienced a loss of a family member or a loss of a loved one, and they're in an acute grief phase, and they don't need to go to a hospital, but they need someone to talk to right at that moment. And they may have a therapist or not, but that therapist isn't going to be available at that very moment. Yeah. But because of my role and how it's mobile and just available to residents in town, I could be somebody that could intervene immediately. So it's grief, it's trauma. Someone might have experienced trauma, whether a victim of crime or assault. So those cases I do a lot of follow-up on. I work closely with our domestic violence detective. I work closely with our school resource officers for students in town that may have interactions with police outside of school hours, on the evenings or the weekends. And I work closely with all the town agencies, Council on Aging, Board of Health. We work together, and I put people in touch with the right resource.
I think that I wonder how you think about this. I mean, I think that when someone is in crisis, they can behave erratically
Yes.
sometimes.
Yes.
So how do you talk to your fellow, fellow officers in the
Yeah.
police department to talk about safety and de-escalation and the possibility of escalation? How do you think about all those, like the potential risks there?
So what's really great is all of our officers are trained in crisis intervention. So every single person in our entire department has had mental health first aid training to recognize mental health issues in individuals. They're also, I think, more than 50% of our department is crisis intervention trained. And we're constantly going through trainings. We have a simulator where we, go through scenarios. So the officers are well trained to deal with these types of mental health issues. Having me there is an added resource, what we say, like I'm another tool, to have. But obviously, if somebody is escalating, we attempt to de-escalate. And many times it's successful. I mean, many times just, interacting with someone, building a rapport and active listening and seeing what's going on, we can de-escalate. And sometimes, of course, you can't. And we make a determination if someone does need to go to a hospital at that point. So having me there is helpful for a rapid assessment, because instead of putting someone in an ambulance to see that mental health professional in the ER, I'm right there and I could help make a decision on what level of care is needed. And sometimes it is a hospital. Sometimes the best and safest route is for somebody to go to a hospital. And other times it's not, but they just need a little more. They might need that, not that level of care, but then that's where I come in, because I can provide that piece that then the officers, can't, because that's not their role, and they go on to the next call, but I can continue to work with that family. So it is something we see.
How much of a shift is that kind of a model of de-escalation, of, maybe triage? I don't know if that's the right word, but maybe it's not the right word, but sort of like in the moment assessment of what the right approach is. The work that you do, the way that you collaborate with the police, how is that maybe different from how things were done 15, 20, 30 years ago?
So I think 15, 20, 30 years ago, many of these instances of mental health, individuals were going to a hospital. Because, the police did their role as law enforcement, what they do, and make sure everybody's safe. And then if somebody they felt wasn't going to be safe alone or in that environment due to mental health or other reasons, they would, try to engage in that person, try to get to a hospital, and if they could agree, and even if they didn't agree, we have rules in effect that we can get someone safely to a hospital against if they don't want to. So I think having me there it's shifted a little bit. It's not all on them, and I think that it's a team approach. And so they'll talk to me. What do you think is going on? And we come up with a plan together. And sometimes, unfortunately, we do. If somebody doesn't want to go to the hospital, but we feel that it is really the safest thing for this person. They are not safe, even though that they are refusing treatment. We can mandate that. It's something, I don't do lightly. It's really like a last ditch approach, but that is there, and it's for their safety.
Right.
But not everybody meets that criteria, and so we want to work with those people, and we work together as a team, and we have different skills. My training is obviously vastly different than law enforcement training, but we bring our skill sets together. They do complement each other very well. I have no tactical training. I don't know the criminal justice training, and they don't have the mental health training, although they're getting better and better at recognizing and the de-escalation skills. It's a great team approach, and I think that it's really taken movement over the last decade or so. There's many police departments that now have an embedded clinician, or at least someone that they can call in.
Yeah. I want to talk a little bit about the difference between those sort of emergency situations versus more chronic conditions, because those of us who are sort of, many of us know that you can experience mental health as like a chronic emergency episode and also as long-term ongoing issues. And so how do you engage with, how do you talk to someone who's maybe not having an instance of, urgent grief of crisis, but a more long-going.
And those cases usually do come to me. The emergent cases is usually like we're on scene, with me or without me, the officers are there on scene in a crisis. The chronic, there are people, every town, Burlington's no different, there are individuals and families that are frequent callers to 911, frequent callers to fire department, and those cases do tend to get referred to me because it's doing the digging of what's going on. There's obviously a need. Why is this person, continuing to call 911? What is missing? What is the help that they need? What are the services or supports that can get put in place? And so those, the chronic situations are the ones that I, continue to work on. And I just try to, continue building my relationship with those people and trying to get them the most appropriate resource for them, to try to, steer them away. Like, you don't have to call 911. There's other resources out there. So those tend to come to me.
Yeah. What are the other resources that are missing often?
Yeah. So I think since COVID, actually, the mental health system has changed drastically. There's a longer wait time, unfortunately, to get into agencies or therapists. Years ago, it used to be a few weeks that I would be able to refer somebody, and then after COVID, the landscape has changed. It's challenging to get the mental health care. It's frustrating for families when they're trying to make an appointment for their loved one and they find out there's a 6-month wait. So I see myself as a bridge, because my role is unique in that I can do short-term. I'm a clinician, so I can do short-term therapy with them until they're situated with their longer-term provider. So people are in limbo between their crisis, and now the crisis has, they've stabilized from the crisis, but they don't have an appointment with their provider for maybe 4 or 5 months, sometimes 6 months. And what are they going to do in the meantime? So I can be that bridge, I like to say, that I can continue to meet with somebody to get them through until they get, hooked up to, whether it's a therapist, whether it's a support group, if it's substance use, whether it's, a partial hospitalization program. So there are resources out there, and they're vastly changing.
Right.
And there's always new things added. So I'm trying to stay on top of what's out there.
Yeah, I think I'm going to sort of stumble my way towards a question. I hope you'll be generous with my framing here. I'm like thinking this through in the moment. In the housing world, there's this concept of like housing first, right? Which is where if someone is experiencing, substance abuse issues or sort of emergent mental health circumstances, or is having trouble finding a job, sometimes if you get them a house, then having a stable place to stay makes it easier to get the other stuff sorted. It's easier to get a job when you have a house. It's easier to deal with substance abuse issues when you have a home. I wonder if in some ways mental health care or emergency care, chronic conditions are the same way in some circumstance. Like if you find in your work that there's some sort of underlying material need that's not being met, that gets in the way of getting to stability in the area of mental health. I don't know if that made any sense. Do you know what I'm getting at?
So what I see is, mental health issues have always been there. I mean, over time, there's always been depression, anxiety, bipolar people. What I'm seeing now that's different, because I've been a clinician for 20 years, and the situations I'm seeing now is the acuity is higher, and I think the cases are more complex. There's so many issues. There's some folks dealing with layer upon layer of issues. The mental health is maybe one piece.
Right.
The other piece is the job insecurity, the housing, family stress, social media stress, it's just, I'm seeing more and more layers. So when I meet with somebody, what I do is look at the whole situation and say, okay, we need to dissect all of these things, and what are we going to work on first? And if the first thing is you're hungry because you're not eating and you need a safe place to stay, then that's going to be the first thing. And not that those other issues aren't just as important, but it's like, what is the priority of what we need to do? And sometimes finding somebody food, shelter, a basic need, they de-escalate a little bit because they feel a little safer, and then we can start working on the other issues. So there's a myriad of issues, and some folks are dealing with a lot of stuff.
And I guess that's where it's helpful to be in conversation with other departments in town to.
Yeah, it's been paramount to my work to be able to have the app basically at my fingertips, all the agencies in Burlington that we work together, and it's great because we can just help an individual in so many different ways.
We're having this conversation around Mental Health Awareness Month, which is May. Part of that conversation is about stigma, and I wonder if you think that we've done it, we've destigmatized mental illness. If you think we've got a long way to go, how are we doing?
I think we're getting better. There's always been a stigma to mental health, and this is an example I use a lot. If you are somebody who you're struggling with, you have a bad migraine and you want to call out sick from work, you might say to your coworkers, hey, I have a really bad migraine, I'm not going to come to work today. Or if you have back pain or whatever. But not many people will call their employer and supervisor and say, I am depressed and that's why I can't come to work today. So people still don't talk about it. I do think we're getting better. I think things like Mental Health Awareness Month, and I think, what the schools are doing, bringing, it's talked about more openly. I think our younger folks are in a much better place than our older folks. I just think that there's always going to be a stigma, but we're getting there. So I don't think it's as bad as it used to be, but people, you've heard the term, it's okay to not be okay. That is something that I think our younger generation is realizing, and people are reaching out more, and they are, because that's why they're bringing on more and more mental health professionals, because there's so many people seeking that help right now. So I do think we're getting there, but it's not where yet I'd like it to be. I'd like it to be equal, that somebody could, it's just as important as a medical problem that you're not coming to work that day. That I think there's still a shame. Some people don't want to say that they're struggling with a mental health issue, and it shouldn't be. There's no shame in having a migraine. There should be no shame if you're experiencing that, and people don't want to label. But you'd be surprised. I think individuals need to know that there's so much help out there, and there's so many more people out there willing to talk to you than you even realize. So we're getting there.
Let's talk about some of that health. I know you brought some resources in, so let's do a little bit of where can people turn?
So number one, always you can call 911, 24/7 911. Our police department is the epicenter of all the 911 calls, and we will get you the help that you need, whether it's dispatching out me with an officer, or whether you're going to get the help that you need. 988 is also another crisis line that started a little over a year and a half ago. It's an alternative to 911. It's a mental health crisis line. Again, 24 hours a day, anybody can call 988 if they're in any type of crisis, or you don't even have to be at that top level crisis. Just if you feel you're getting near a crisis and you want a trained clinician to talk to, they will loop in 911 if needed and send an officer to you if they feel that is, warranted. But it's a great resource. It wasn't even there 2 years ago. The state of Massachusetts has a mass behavioral health helpline, and a lot of people don't know about that. That started a year ago. It is a number that is available 24/7. It's not a crisis line. It's if you're looking for resources, looking for someone to talk to, you might be having a bad day, you might be feeling depressed, and that is available 24/7 in like 30 languages. It's an amazing resource that a lot of people don't know is there, and the people on the other line are going to listen to you and connect you to the resources that you need, so that they have all that at their fingertips. So that I feel like a lot of people don't utilize that line, and it's wonderful. It's in our state. It's for the whole state of Massachusetts. And then a resource that I like that a lot of people don't know about is for our younger folks. If you're up to age 24, you can text Hey Sam. It's under the Samaritans, and you're just texting the letters Hey Sam, so it's 439-726. It's a text line for teens run by teens, so there's teens on the other end. So if you're 16 years old and you're having a hard time with your friends at school, or just having a hard time at home, and you want to talk to somebody outside of your friend group for confidentiality, you have a text line, because we all know that our teens like to text. So there's a text line available that they'll talk to someone their age, their cohort. And again, if it's a crisis, they will bring in the appropriate people. But I think that that's a great resource that a lot of people don't know about, and I think our younger folks would really benefit from that, knowing that they're talking to someone their age.
That's so wonderful.
Yeah.
Thank you so much for bringing that to our attention. Karen DiRienzo with the Burlington Police Department, thank you very, very much for being with me.
You're welcome.
This has been a conversation about mental health in Burlington, here on BNEWS In Depth. Thanks so much for watching. If you're in distress and need support, help is available. We'll leave you with some resources.